We've had a number of reviews over the year that have highlighted some opportunities for improvement. We spent some time this morning looking at the latest data on that, which again identify how we could ensure that our patients get the right care at the right time in the right place. Ideally, that's at home. And so we will be encouraging a service delivery model that keeps people home, that gets people home quickly if they need to be in hospital, because we recognise the harm that can occur if you stay in a hospital setting for too long. So we will be tackling those ambulance delays that you referred to at the start of the meeting, Chairman, and there's a few things to do that, some structural changes in the organisation, but a better connection between the activities at ward level and particularly our general acute patients and what happens at the front door, at the busy front door of the hospital that we've just had the pleasure of turning into an even better A&E. We need that A&E will only function if we achieve flow out of the A&E so that it can focus on what it's there for. So that's a big element of what we will focus on, and our primary focus is on what we can do. There is a system around us that can help with that, but our focus is on how we can make improvements within the acute pathway. There's then a reference to a home first mindset. There's a communications exercise that is commencing across the integrated care system. We're also doing this across the group, and that is linked to the point I've already made about trying to ensure we get people home as quickly as possible, and indeed when we get them home, we try and get them home in the normal hours of the day rather than in the middle of the night, so that they can ensure the right support is there for them. So that exercise is going on. There's a mindset change that I think we need to achieve here with our communities, which is that it is the safest place to be. Discharge sounds so fine, or what we need to be talking about now is how we're moving patients from one part of our system to another part of our system, and that other part of our system is supported by our great community teams, our primary care teams, and we will outreach and we will use technology to facilitate that. So focus on flow, home first, and the only other one I wanted to talk about is about our staff. One of the other big pressures which we'll touch on when we look at our finances relate to the dependency on agency staff. Agency staff, whilst they're suitably qualified, are not always familiar with the local circumstances. So it's always better to employ our own staff. And of course, that is the less expensive way to use our resources. So we will be tackling that. We will continue to drive to make the organisation the best place to work. There are some very specifics that irritate our staff, and I referenced the one here about car parking at Worcester Acute. And so we will be doing some things to improve that. That's an important thing for staff and visitors. So I'm not going to go through everything I said, so I'm going to stop there, Chairman, and all the other elements of the 10-point plan are in front of us, so happy to take any questions on it. No,
great point, and thank you, Glenn, and thank you for your hard work that I know you've been putting in to pull that together with other colleagues. What I would say to members of the public is the issue that Glenn touched on, home is best. The evidence for hospital-acquired functional decline and hospital-acquired, it's called delirium, but basically it's getting confused if you're in hospital when you frankly have been there more than is good for you. The evidence is really very, very clear that hospital is absolutely the right place for you to be when you need to be in a hospital. But generally, home is best, particularly when the acute episode is sort of finished. So questions and perspectives, Callum?
Thank you, Chair. Thanks, Glenn. Very supportive of the plan and the clarity around it. And I guess I just wanted to query what the plan is or what's being developed to share that within the organisation. Obviously, it will be going out through all the comms channels, but clearly it lends itself to discussion and debate in order to make sure it lands in the right way. And I just wondered what the plan was around that, so we can feel confident that everybody will understand what the priorities are?
Yeah, good question. So importantly, as I said at the start, this has come from a lot of the things that people have said to me. So when people, certainly staff, see this plan, they can see elements in it that they would put in a 10-point plan given the choice, but also elements that they can help to deliver. So I've already gone through the components of this and identified lead executive directors and some activities that will support the ideas that were within the plan. I've already shared it with our senior leaders and had positive confirmation from them that these are the right things to do. We will do, though, a bigger communications exercise to ensure that the plan is understood by everyone. And I think as a board, it should start to structure our work plan, actually, to make sure that we're making the progress that we want to. But a key component of this for me is to ensure that at all layers in the organisation that there is a connection between these items and the things that we prioritise for them to be acting upon. So the divisions, the specialties, the managers, the clinicians that work hand in hand in those areas. So we will be making those connections as we articulate this plan across the organisation. As I say, I've shared it with senior leaders, I've shared it with consultants, but if it's all signed off okay by everyone today, we will then start a wider communications exercise.
That's great, Glenn. And I think for patients and their families and our citizens generally, if we implement this 10-point plan, they will see a big impact in their experience of visiting and staying in the hospital. Tony?
Yes, thank you, Chair. Like Cowan, I too welcome the clarity of the plan and its focus, and I'm fully supportive of it. Just a couple of observations, if I may. One is on the statement on the forward improvement programme. I'd also like to see an emphasis on it being very responsive and flexible to changing circumstances and not too fixed, because as challenges come up day by day or week by week, we need to be fleet of foot enough to be prepared to do other things, is what I'm just going to say. The second is about language, and I know there's going to be a comms exercise on this, but further down on that page we use the word tertiary, which I don't think is a very friendly word, and I always have to stop and think, what does that mean? Is that up or down from us? So I just think, just in terms of a simple language thing, finding something which is a bit more accessible. Thank you very much.
No, great point, Tony. Thank you. And Richard, your hand went down. Are you okay, or did you want to make a
Glenn actually covered most of the points that I would have made for the benefit of colleagues. I know Tony's comment about tertiary, and we'll have a look at that because we will be looking to make this have a visually slightly more appealing version of this to underpin some of the corporate comms, Chair, as well as to Tony's separate point about the forward improvement system, trying to align more of the comms we do around the forward improvement system work with the top 10 priorities so that they are that work and the work of that team is linked more closely to the top 10 priorities. And those conversations have already begun with improvement team colleagues as well.
Thank you, Richard. And Joe?
Yeah, just to build on that, as we're entering the second half of the contract, we are just doing a review of how to make sure it's fit for purpose and actually works to the needs for both all of the staff, but also to deliver our strategic objectives. So that will come through in the next month or so. And colleagues will be invited to give some feedback. Thanks, Joe. Well, when you say the contract, you mean with Virginia Mason? Yeah, so we've got a supplier relationship with Virginia Mason. Yeah. It's just, it wasn't clear. Any other comments or perspectives on the 10-point plan?
Russell, could I just respond to Tony's point, if I may? So, it's really important that every NHS provider has an improvement methodology, and looking at the forward improvement system, it's a good one. It works. We've got different methodologies elsewhere in the group, but that doesn't mean we can't share between the members of the group some of the improvement work that's going on, so we can learn from each other, whether that's learn from things that went well or things that didn't go so well. But I think the cultural approach to improvement is a really important thing to get right. We need to be permissive, and I think that's what you're saying. I think we need to be able to respond to emerging issues, problems that we highlight, that staff highlight. So that degree of flexibility, which Joe's just referred to, I think is a really important element of that. And still, the aim is to get as many of our workforce using these methodologies as possible, ideally because they're hugely enthusiastic about it, and that's what we will be trying to ensure moving forward.
No, thank you, Glenn. Any other comments or perspectives? Okay, as Glenn indicated, we have talked about this quite a lot, so turning to board colleagues, if you're not happy to approve the 10-point plan for implementation at pace now, please raise a digital hand. Okay, super. Full steam ahead then, team. Thank you very much, Glenn. We then move on to our patient story, and delighted, Annie and Tracy, that you've been able to join us. Sarah, I think you'll be doing an introduction in just a second. Just so members of the public are aware, we are, over the next couple of months, going to have patient stories which focus on the consequences of being in hospital too long. What I mentioned about hospital-acquired functional decline and hospital-acquired delirium. In fact, members of the board, I know, have had loved ones who have been affected negatively by being in the hospital for too long. So that will be the subject over the next few patient stories that we have. But like I said, Annie and Tracy, really appreciate you giving up your time today to talk to us. But Sarah, do you want to do the proper introductions, please?
Thanks, Russell. A warm welcome to Annie and to Tracy, and also to Ben Furlow, who is supporting Annie and Tracy today. I'd just like to say a big thank you for sharing your story. It's just an invaluable tool to hear firsthand people's experience of using our services and being treated by our clinicians. And we understand just how difficult it is to come into a board and describe your experiences. So thank you so much for that. And I'll hand over to you both now.
Hi. Thank you for that welcome, and to the board for giving us the opportunity to speak. Can you hear us okay?
I can hear you perfectly.
Can I just fire a bit of a warning? We're on our narrowboat and we are typically having some work done on it today, which is just bad timing, I'm afraid. So I'm hoping we're not going to have any interruptions.
There may be some background noise.
Yeah, but, I do apologise. So I'm Annie, this is Tracy.
Hi.
So just to give you some background on our story, our journey, in February 2022, last year, I was diagnosed with rectal cancer as a result of a colonoscopy. Very, very quick referral from the doctor, and then I had an operation about 6 weeks after.
Yes.
Yeah. So absolutely superb. As a result of having the op I had, I've got a permanent colostomy, which I'm handling absolutely fine with excellent support of the stoma nurses employed by the trust. So I've really got very, very positive.
I think that we both have. I mean,
yeah,
the one or two little bumps in the road along the way, but in general, we're happy with all of the care that we received along the way.
Yeah, indeed. I'll just say, following on from the op that I had last year, just want to pinpoint some of the real positives of the care that we both received. And this is an ongoing thing. It isn't just being a cancer patient and having an operation, which the colorectal team and the surgeon were fantastic. It's an ongoing thing, and I actually think mentally I'm probably worse now than I was 12 months ago.
Work through it, Annie. Just carry on. Don't worry about the knocking.
Sorry about this.
But yeah, just to pinpoint some of the real heroes, I suppose, are, well, things like the wellness days, that was something that I was introduced to in November last year, which gave a huge range of important information, including something that I've followed up a lot since, which is Active Always fitness that I attend every Tuesday. Well, I try to attend. We've had an extended holiday this year, so I haven't been there quite as much as I would have done historically. That gives us opportunity not only to keep fit, so rehabilitation has been a key thing, but also to meet other cancer sufferers, so not just bowel cancer sufferers. It's also given me the opportunity to after the event chat through, have coffee, healthy snacks, and you share one another's woes. We're all at different stages in our journey, and it's been incredibly important to me to attend those particular events that are run every Tuesday. That's been absolutely superb. And then other things, so the wellness days, fantastic. That's actually how I heard about Di's Active Always.
I think some of the support groups, we've attended quite a few support groups. They sort of take place in hotels or pubs or whatever throughout the region, and those are meeting people that are either going through the treatment or have come out the other side, and you get great encouragement from people that have that attend a 5-year sort of cancer-free, and we didn't think that was going to ever happen, really, if we're honest.
No.
I mean, we are brutally honest with each other, by the way. So we're very open about these things, and I think it's a massive big win for us to go there. And we attended the Christmas lunch last year, and there's people there cancer free for 10 years, and you think, wow, this is we knew nothing about cancer, really. We knew it was bad, but that's about all we knew from last year. But we've learned so much along the way, and I think that's testament to a lot of the people that Annie's spoken about. The staff, the support groups. It sort of broadened our horizon, really, and we know so much more. And we want to impart some of what we've learned into other people in these support groups, and I think it's a great forum. It really helps us, and I hope that we can help others along the way.
Yeah.
I think just touching on the sort of learning curve that we've been through. I think the very first introduction for us was when you had the colonoscopy, and the experience we had. We've written in the notes of the experience, and from a lessons learned, my personal view, and I don't want to be knocking anybody, absolutely not. This is we felt that the delivery of that bad news, and I don't know how you deliver the bad news in a good way. I don't have all the answers, but we walked away from that sort of delivery of the news that Annie had got cancer, feeling that this was the end of the line, and it was really, 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 it was going to be terrible for us. And I think we could probably learn to soften some of that delivery of the news. And to just give you an example of what happened to us, and this was during COVID. So I dropped Annie off, and then I went home, and then I was called back, and the consultant met us, and he basically said that Annie had got cancer. If it was localized and it hadn't spread, it's easily fixable. If not, there's probably nothing that they can do. And that really, it was like a punch in the face. It really, really, it was a real, I don't know. I know these guys are really busy. To sort of put some perspective on this, these guys are really busy, and they see a lot of people every day. And also having to deliver bad news to the few people that have that is a really tough ordeal for them. So there's no easy solution on this, but I just think in some way, if we can learn to soften some of that, what we now know from that experience is actually from the the colonoscopy, they probably couldn't tell us much more than the fact that we'd got cancer. And if they'd have told us, I'm one of these facts and figures people. If you tell me the reality, give it to me straight, I'm much more comfortable with that. That doesn't speak for everybody, but if he'd have said to us, look, with the equipment I've got today, I can tell you that there is cancer present, but I can't go any further than that. But having delivered the news in the way that it was, we left there thinking he knows a lot more than he's letting on here, and we felt that maybe this is really bad news and he doesn't want to tell us that. So I think to turn it round and say, I can't actually tell you any more about your diagnosis. And I think that was a key part for us, wasn't it?
Yeah.
That was a major sort of, because then you sort of sit waiting for 4 weeks before you have a consultation, which, and the consultant was absolutely fabulous. We had because it was COVID times, we had a telephone conversation, and she really put our minds at rest. It was just a complete flip side of the experience before. So I think everything's working from from that perspective. Just maybe some lessons learned and how to soften some of these. There was a nurse that was with us at the time when the consultant delivered the initial news, and maybe she would have been better to speak to us than the consultant. And I understand that, you probably have a protocol which says there has to be a consultant present to deliver that news, but I don't know whether that's wise. I think maybe some of these specialist nurses maybe have a little bit more empathy. That I don't know. It's as I say, I don't have all the answers, but that's the experience that we had.
Mm-hmm.
I think, Tracy, it's a really important point you make there. I'm a cancer survivor as well, but I'm not sure if you're Strictly fans. But Annabel Croft, who's on Strictly, she talks now, who lost her husband earlier on this year, talks about the experience of the way the consultant gave the news about her cancers, her husband's cancer, and how that still causes trauma for her. So I think it is a very difficult conversation to have. It's certainly not a conversation I would want to be having with anyone, but I think what your story tells us is how important getting the empathy across is, rather than it just being a very matter-of-fact type of discussion. Really appreciate your story, and I'm glad that you're enjoying life, so to speak, and getting the boat repaired by the sounds of it in real time.
Sorry about that. Yeah. We've had the summer out to be able to do that.
Yeah.
So
I think just touching on what you were saying, Annabel Croft is suffering the trauma still. I don't think we are, to be fair. We quickly overcame that when we spoke to the consultant surgeon, and she was fabulous, absolutely fabulous, and this was done all over the phone as well, so it's even more difficult for her. But we the treatment went really well. The chemo was a really rough ride, as you'd expect. I think the sort of mental side of things kicks in after a while, doesn't it? Because
and I've used I don't know whether you're aware of it. There's an app that's delivered via. I know Ben has been involved in
the Health Zone.
Yeah. So for me, I've used it in various different ways, but for me, the most important thing to draw out was the fact that I've been able to access some counselling from Macmillan. It's actually a joint venture, I believe, between Macmillan and Bupa, but I've accessed that through the app. To get some counselling sort of 12 months on, which is when I started to really struggle, scare of reoccurrence, etc. So that's something that I've had an extended counselling now, which is, so it was 6 weeks initially, and it's been extended to 10 weeks. So that's been absolutely brilliant.
I agree.
You've got some comments on that.
I think the meet the team section to have photographs of people that sort of you're going to eventually come across at some point during your journey, and all the videos. And the contact section is really, really important, because it's almost like you need your nurse specialist on speed dial for the first few weeks, and to have that all available in an app. Oh, and by the way, I'm a software developer, so one of my pet hates is really rubbish apps, but this is not a rubbish app. This is well put together, so congratulations to everybody involved in that. Yeah, I think that's
probably sums it up.
Yeah, probably sums it up.
Journey, yeah. So far, so good.
That's great. Thank you, Annie and Tracy. I appear to be having, I think, a problem with my camera. Ben, is there anything you'd like to add?
No, just to say, pass on my thanks again to Annie and Tracy for taking their time out to come and present to the board today. And I think I've worked with Annie and Tracy for over a year now, and they are great. They really engage with all of the services that we have to offer. And when I started building the app, Tracy was one of the first people I showed it to, because I knew about his software background. So I thought he's going to be a tough crowd to please. So yeah, if he gives it the thumbs up, then I'm okay. So I think they're both a sort of shining example of how patients engaging with the aftercare, with the wellness days that we put on as a team, and attending the patient support groups. I just think it shows how important those are for patients, because it doesn't just stop at the clinical care. It's a lot around the holistic that's after the event. So I think yeah, I really appreciate everything that they do for us at the support groups, and their feedback is they're very honest, which is great, because it helps us grow our services and make them better for patients. Thank you.
That's great. Thanks, Ben. Any other comments from colleagues? Okay, well, Annie and Tracy, carry on enjoying the extended holiday, and hopefully it's warmer with you and it's not too blowy with this storm coming in, but if you're on the canal. And take care, and we hope your journey with us and the journey with your recovery continues to go from strength to strength. And I think what Annie and Tracy's story also illustrates to us is there are so many good examples of great work we do at Worcester Acute, which we can be really proud of. What we need to ensure is that all patients' experience is as good as Annie and Tracy's has been, and that's our collective challenge as a board and as a senior leadership team. Okay, thank you very much. Take care. You can't see, but I'm waving at you. So we'll move on then to the integrated performance report, and I'll hand over to Christine and Neil to introduce that. Christine and Neil, over to you.
Thank you, Chair. Neil may be at a different meeting. I think he was attending the a regional quarterly review meeting. We are presenting the IPR in our joint roles as Deputy Chief Executives until Stephen arrives, in which case he will introduce the IPR for us. As has already been discussed, we continue to focus on improving urgent and emergency care flow through the hospital. When at the time of writing, we were just waiting to open our new emergency department. As you all know, that's happened, and a very lovely space it is, and a much better working environment for our staff. We heard in the board development session earlier about the MAID event, the purpose of which was to improve discharges at the end of the week leading up to the opening of the new emergency department, so that by the time we moved into the new department, we only had today's work in the new department as opposed to doing yesterday's work today, in line with our patient flow improvement plan. We also had, during the course of September, industrial action to contend with. So junior doctors from the 20th to 23rd of September, and consultants from the 19th to the 21st of September. On those overlapping days, both groups of doctors provided a Christmas Day service only, which did result in some elective activity being cancelled. I have to commend the the work of the clinical and operational managers who worked really hard to ensure safe levels of cover were provided during that time, and there were not any clinical safety incidents directly as a result of the industrial action because of the hard work to provide cross cover for the doctors who were taking industrial action. Of note, we also opened our new West theatres at the Alex. They're huge by comparison to the old theatres in the complex, look really modern, and will be key to enable us to progress our elective recovery plans. I would also like to commend the digital team and the ITU clinical and management team for the introduction of their new electronic patient record. The introduction went very smoothly, and we know that that has saved 2 hours of nursing time per day by allowing patient observations to be entered directly into the EPR rather than transcribed by nursing staff. And we think it's also saving on average 2.5 prescription errors per day due to electronic prescribing. Less good news is the financial position. In August, we overspent against our plan by a further 1.8 million, bringing our cumulative overspend to 8.2 million. We're therefore undertaking a reforecasting of our position at the moment. Some of it was one-off expenditure, including the cost of the industrial action, and some is due to high bank and agency spend, partly due to the industrial action and partly due to staffing overspill capacity throughout our organisation. I will leave it to my colleagues to talk in more detail about their sections of the IPR.
Okay, thank you very much, Christine. Now, before we move on, any questions to Christine before we go across onto operational performance? Okay, thank you. Can't see any hands raised. So, Helen, how are you seeing things?
Thank you, Russell. Well, I think I'll start with a very, very positive note. So, as mentioned earlier on, we opened our new emergency department on the 16th of October, and it's, for those of you who've seen it, and we talked about it, I think, last month, is a beautiful department. I think it is fair to say that working in an environment that's considerably different from the environment that the staff have been working in the past has given some challenges in terms of space, in terms of they've got so much more space and where things are situated. So there's a few little teething problems ongoing, but nothing that can't be resolved. I think what we did do prior to the move was have a real concerted effort across the whole of the organisation to make sure that we were in the best possible position we could be to move into the new ED and make sure that it functions as an ED, which is doing today's work today rather than still doing yesterday's work. And so far this week, and we've just got to hold on to these things because we really, really need to hold on to the positives. We've seen a 50% reduction in the over 1 hour ambulance handover delays, 50%, which is a tremendous effort by the team. And I know this is an accumulative effect, but so far in the week, we've seen a 10% increase in the 4 hour access target and the A&E standard. So, as I've said, it's a new working environment. The team are still getting used to that, but there's some really, really good green shoots in terms of how we're managing flow across the trust. I think it is as we've said, it is our number one priority, and Glenn discussed that in his 10-point plan. So there are many plans in place within the organisation about how we maintain that improvement and start to improve the working practices across the organisation. The next thing I wanted to highlight is really pleased to say that due to the exceptionally hard work of the teams, we have been removed from the Tier 1 oversight arrangements for elective recovery. Now, that doesn't mean to say that we're taking our foot off the pedal. We're absolutely not, and we are driving forward with the teams that productivity piece of work, and making sure that we're doing all the things that we possibly can do to ensure that all of our patients that are over 65 weeks will have their an outpatient appointment by the end of October. So some really, really great work. Again, still have to drive that harder. Cancer still remains a challenge for us, but every specialty now has a recovery plan in place with trajectories set. And the key thing for us now is driving the 28-day faster diagnosis standard, because the sooner that patients get a diagnosis of whether they have cancer or not, the sooner we can move on with treatment, or people can just go, oh, thank goodness I haven't got cancer. So there's some actions in place that you'll see in the report that we are driving hard with the teams now to make sure we're delivering the national standard of 75%. We're at 69.4% at the moment, which is just below that. So not much more to go in terms of driving that, but we want to be better than that. So lots and lots of focus on that. The last thing I want to say on cancer really is that we have seen a significant increase in the number of 2-week wait referrals for dermatology. And as we've talked before, dermatology is quite a fragile service, and so that has impacted a little bit on our performance with dermatology. And we are continuing with our partnership arrangements with Wye Valley and Gloucester to improve, and Northampton actually to improve our urology service. Productivity, as I've said, particularly in theatres and in outpatients. Now we've got our new theatres open, we really need to be maximising those opportunities to improve our theatre productivity. And Glenn's already mentioned in his report about the Going Further Faster programme. And so as a team, we're looking at how we can embrace that programme and be part of that moving forward. I don't intend to go through any detail within the report, Russell, because it's all there for everybody to see. So I'll just take questions.
Thank you very much, Helen. Thank you for your hard work. Any questions or perspectives to Helen? Okay, thank you, Helen. So I think over to you, Vicky. Are you with me, Vicky?
I am. For outpatient transformation, is it, Russell?
No, it's just your part of the
the data IPR. Quality piece. I'm sorry, I hadn't turned that page off, so please bear with me. So just in terms of our data quality maturity index value of 92.5, that was the latest data published as of May 23, and we remain higher than the national average, and just goes to prove how much hard work actually goes on with operational and clinical teams around that data quality piece. In terms of improvement opportunities, we're looking at the emergency care data set, and that will be dependent on the implementation of our electronic patient record at phase 7. Just for reference to the gallery, we've actually just delivered phase 3 successfully last week in the midst of the MAID event, which we've referred to earlier on in the meeting. And just in terms of also our referral to treatment pathway and the patient tracker list, that's at 99.48%. And we've got a number of pathways there, quite a low percentage actually, in terms of a possible data quality error. And this was an internally built data quality tool that we actually feed into our data quality dashboard, and is supporting the validation exercises, which is really important in terms of our operational delivery of performance standards. We're currently undertaking a particular project around active monitoring report, which operational and clinical teams will use to ensure that patients are being booked and seen within those target booking times. And that also helps support the outpatient transformation programme as well. And as it references there at the bottom, I've said earlier, our EPR programme is absolutely vital to ensure that data quality is kept up to date. That's really important to ensure that we have the right information available to our clinical teams as and when they treat patients. I'll leave it there, Russell, if I may.
No, thank you, Vicky. Any questions or perspectives to Vicky? Okay, thank you, Vicky, for your hard work. And so we'll move on then to quality and safety. And Sarah, do you want to go first and then Christine afterwards?
Yeah, that's lovely. Thanks, Russell. So I want to pull out two areas, if I may, which is firstly is infection prevention and control. So we are having a challenging time with outbreaks. So we've had CPE outbreaks, C. diff outbreaks, which are active at the moment, norovirus, with one of our wards being closed, and 7 wards which are active with COVID cases. Now, obviously, this does have a significant impact on how we can manage flow across our hospital sites. Regional team have shared some concern around the number of outbreaks. But if we look at the ED overcrowding, the amount of corridor care and boarding that we are doing on our wards, we know that these are all the fundamental factors that will contribute to outbreaks occurring. We are seeing a decrease now in our COVID numbers. So as of today, we have 57 active cases, which is providing some respite across the site and the flow relation. And in relation to the flow and managing the flow and managing the risk of ambulances not being able to offload at the front door, we do have to make some decisions in relation to what we do with filling beds which may be blocked on infected wards, and that's something that we risk assess and we make as a triumvirate decisions. The second point is around complaints. And we still have high numbers of complaints that are overdue. The main division where we've got the cause of concern is in surgery, and women's and children's are also have some complex complaints, which is now contributing to that backlog. But there is a programme and a trajectory in place for children's. Surgery continues to be more challenging. But we have now secured additional support into the surgery division. The trajectory for full completion of all overdue complaints is at the end of November. And I am now more confident that will be achieved for the quality of the support that is now in the division. We've also commissioned a specialist governance lead who is currently working with the divisional team to do a review of the governance arrangement, so how the division are managing their quality, governance and risk processes. Myself, Helen and Christine are expecting that report to be with us by the end of next week so that we can look at what other support is needed. So I'll stop there. I'm happy to take questions on the rest of the IPR, but hand over to Christine.
Okay, Christine, over to you. Anything you'd like to add?
No, just reassuringly. So members of the board will remember that a few years ago, about 3 or 4 years ago, we had elevated SHMI and HSMR within the trust. The improvement actions that have been taken, despite the operational pressures and overcrowding of our hospital, have resulted in a consistently normalised mortality rate for the trust, and that remains the case today. I've included in the report the number of externally reportable serious incidents, which the commonest was healthcare associated infections, which aligns with the concerns that Sarah has highlighted. I've included something about 2 never events, one which occurred in June, and the investigation of that is now completed. It was an individual error, which has resulted in some further training being given. We are currently investigating a never event, which was of a small needle left in a wound at the end of an operation. I think that's all I'd particularly like to highlight from a quality perspective.
Thank you, Christine. And thank you, Christine and Sarah, for your hard work. Questions and perspectives, Tony?
Thanks, Chair. I wonder if I could specifically ask about our response to the deteriorating position on the use of the sepsis bundle, which I see there's a reference to a workshop being held quite recently. I also raise this in the light of there's been some very high-profile cases reported nationally about, particularly for teenagers, being missed, what were possibly avoidable deaths in those two instances. Because our compliance seems to be quite low, and I think it's been a bit of a struggle to get it up. So I'd just be interested to know what we're doing about it and whether we think we're going to be successful. Thank you.
Yeah. So our compliance with the sepsis bundle at the moment is reliant on a manual audit, which entails putting a sticker in the notes. Now, our performance has deteriorated since we introduced the electronic patient record because people are not using the stickers, and therefore we're having trouble auditing. We've done some improvement work in a workshop, as you know, about how to record the elements of the sepsis care bundle. When we do audit, the key measure of administering antibiotics within an hour of identifying a patient with sepsis, we do usually achieve that measure. It's other elements of the bundle, such as recording the urine output or measuring the lactate, where we often don't succeed. There is a new new module being introduced in the EPR, which will trigger use of the sepsis bundle for any deteriorating patient with a new 2 score of 5 or greater, and that will improve our ability to be able to audit and therefore feed back to those areas where compliance is less.
Okay, thanks, Christine.
And I'm sure Vicky wants to talk about that.
Yeah,
Vicky, thank you, Russell. Just to say, Christine, the phase 3 drop that went live last week included the sepsis assessment, as you've just referred to. So hopefully we'll start to see an improvement. Thank you.
That's great. Thank you. And Sarah?
Yeah, just to add quickly that one of the areas which is struggling with sepsis is the ED, and what they're doing is actually putting a quality huddle board in place of which sepsis and the descriptions that need to be completed on there, and they will do a daily huddle with their whole team, and then they will audit the progress on that on a twice weekly basis to kind of get the QI and what needs to change within the department to achieve it.
And reassuringly, our mortality from sepsis is actually slightly below the expected range, and we haven't had any unexpected deaths from sepsis.
Okay, thank you. Let's keep an eye on that, and hopefully the numbers will improve with the EPR new version going out. And any other questions? Otherwise, we'll move on to workforce. And Tina?
Yep, thank you, Chair. So we've been focusing on the areas to reduce our reliance on the temporary workforce and therefore on the premium staffing costs. So 3 things to update, please. First is that we have now started seeing benefits of the investment in our central recruitment function. So we have seen more staff in post and an improvement in our turnover rates. And we're on trajectory to reach both targets for our vacancy rates and staff turnover by the end of March. So that's positive news. Where we've not made the traction that we would like is with sickness absence. And as mentioned earlier in the meeting, we've amended our target down to 4% to match that across the group. We did take a deep dive report to the People and Culture Committee in June on this and are undertaking a number of actions, including updating our health and wellbeing offer for staff. But we've yet to see that impacting on our run rate of sickness absence. We've reviewed all the long-term sickness absence cases, but we're now working with occupational health and the health psychology team to have a real focus around support for colleagues with mental health, because we are seeing an increase in that area. And the last area to talk about is job plans, where there were concerns raised by board previously around the compliance with job plans. We have seen improvement this month up to 81%. We did take a report through to People and Culture Committee this month, and we will be taking a deep dive report there. So there's further actions to take to ensure the quality of the job plans linked to activity. So happy to take any questions.
Thank you, Tina. Thank you for your hard work. Any questions or perspectives to Tina? I think it's stating the obvious, Tina, isn't it, that it's better to recruit our own staff rather than have to use agency. Agencies are incredibly expensive. I would say to people considering a career in the NHS that it is a wonderful thing to be able to do. Tell people like Annie and Tracy that we were talking to earlier. The money's good, but the pension's fantastic. So I would strongly recommend a career in the NHS for those considering what direction to take in life. Okay, so we have apologies from Neil. So I think, Joanne, are you sort of standing in for us? You are Neil. So we spent quite a lot of time on finances this morning, Joanne, but what would you like to pull out of the report?
Okay, so thank you for the introduction earlier, Christine, where she highlighted we've got an 8.2 million adverse variance at the end of month 5. So in terms of the monthly variance, that was 1.8 million, which is consistent with last month. And what we are seeing is a continuation in those themes. As can be seen from the report, we've categorised the variances into those 3 categories. So timing as a result of the consequence of the final plan. What you'll see when you compare to last month is that we are starting to see a downward trend in that adverse variance, and by the end of the financial year that should be removed completely. Our exceptional items continue, so we've incurred costs associated with industrial action, and as we heard earlier, we continue to report on those. PEP is one of our largest contributors to our variances, and at the end of month 5, that's 2.4 million. What we can see within the pack that we're seeing some movement in the maturity of our schemes, which is a positive movement, and we continue to hold it through the transformation delivery board, those regular meets through that forum, holding the SROs to account and also supporting with traction on those schemes. The cumulative deficit at the end of month 5 is 16.3 million, and obviously that remains a concern. And as we heard from Christine earlier, we continue to work through the forecast scenarios and share those with our Finance and Performance Committee. Moving on to capital, so we remain challenged in this area. Discussions are progressing with ICB and NHSE to support with brokerage and manage that level of risk for this financial year. There's a meeting that's taking place next week, so it's obviously high on the agenda. And from a cash perspective, finally, so as per that's outlined in the report, a cash balance of 5.1 million at the end of August. Obviously, the cash position we will manage very closely with our forecasted position, and we'll return to Trust Board with an application for support aligned to our forecast.
Joanne,
thank you, Chair.
Very much. Very clear. Just before I invite questions or perspectives, we have had quite a discussion on our financial outlook, Glenn, this morning. Is there anything you'd like to add to what Joanne said?
Yeah, thank you. Thanks, Joe, for going through that. We talked this through this morning. Obviously, we're looking at the numbers carefully. I mean, a realistic assumption is that we're going to be at a position of around 35 million deficit. So we do need to therefore focus down on the plan that we have. This isn't about us producing a new plan, but it is about making sure that the plans that we put in place are delivered. So that does mean an increase in focus on that and some more governance and a bit more grip around it, which we're discussing as a board. Probably also worth mentioning the managing our finances was not in the 10-point plan deliberately, because the 10-point plan will help us to manage our finances. So the focus on flow, the focus on reducing agency staff linked to looking after our workforce are really important components in this. So we'll be doing some more work. We'll be sharing the analysis of this across the organisation to ensure that each part of it knows what its role is in improving the position. But that's the scale of the problem that we face, which is not uncommon with other parts of the NHS, but we need to make sure that we've got a grip of it.
Absolutely, Glenn. Thank you. And any questions or perspectives to Joe or Glenn? as Glenn said, Joe, thank you very much for your hard work, and please thank everyone in the team. Okay, we'll move on then to the committee reports, and the first is the Finance and Performance Committee Assurance Report of the 27th of September, which I'll take as read. Are there any questions in Richard's absence that colleagues would like to ask? Please raise a digital hand. Okay, can't see a digital hand raised, so I'll move on to the quality governance. Justine's gesticulating, but I think that's not towards me. So we move on to the Quality Governance Committee Assurance Report of the 28th of September. Julie, anything you'd like to add?
A lot of it's been covered or is going to be covered in the board today. It was a very full meeting and there was a lot of escalations from both the medical director and chief nurse this time. I think the one thing that we haven't mentioned today is concern was raised about some of the urology pathways, and so Christine's kicked off some investigatory work which will be coming back to committee in the future. We spent a lot of time on infection prevention and control, but we've got the bed cleaning report to come, and you've already heard from Sarah about it earlier on. So the rest of it I think I'll take as read. A lot of work went into that last committee, so thank you to the teams.
Thank you, Julie, and thank you for sharing it. Any questions or perspectives to Julie? Okay, can't see a hand raised, so we'll move on then to the People and Culture Committee Assurance Report. Karen, is there anything you want to add to this?
Just one thing very briefly, Chair. I was going to highlight that we increased the level of risk around job planning compliance. So it's really good news to hear Tina's report that those figures are going up, although clearly we'll still be keeping an eye on that, but that's really positive news.
Great, thank you, Karen. Any questions or perspectives to Karen? Okay, can I just sorry, Joe?
Yes, just to share that we did take the NHS impact self-assessment through People and Culture this month on the anticipation we were going to have to submit that to the national level, and because of timings we had to do that earlier. So just for awareness for the wider board that actually that's a useful baseline for us to use for the review I referred to earlier.
Okay, thank you, Joe. Okay, thank you, Karen. Thank you everyone who is involved in those subcommittee work. And we'll move on then to the maternity safety report. And Justine, I think we've got you with us. Yes, Justine, over to you.
Thank you, Chair. Apologies for the gesticulate. Just making sure that the background office is quiet, ready for this report. So this is the maternity safety report for August with insurance level of 5. You'll see that the report has previously been to private board, but it's here today because we have made some adjustments, and it's very safe for us to be able to bring it to board without causing any breaches and families' anonymity not being maintained. So I'm just going to give an overall view really. If you look at the KPIs, it looks quite like things are not improving in the direction that we'd want them to. We have realigned the targets to the group targets, but if you look more closely, you'll see that in the majority of cases things are actually improving and going in the right direction, or they're stabilised. There's just one area where we still need some focus, and that's obviously with our vacancies and turnover with our support team, and we've talked about that, and we're actively recruiting quite soon for that group. We've also got a practice development midwife in post to support that team as well, develop them and hopefully retain them in the future. A couple of other things that I just wanted to draw attention to was I know that Sarah has made you aware that we've had our announced CQC visit last week. And I know that she's appraised you of some of the feedback and the positives, as well as some of the items that we do need to focus on. We've got quite a clear action plan already to address the majority of these issues very quickly, and we're hoping to be able to send a response back to CQC by next Friday with the majority of those actions completed or evidence of them being very much in train. So that's a summary for that. At CNST, you'll see that we continue to make good progress on this, and we'll have our board declaration ready on time. And it's also, you'll see the Cosmos platform talked about within this report. That is a platform that we have developed locally. It enables a large volume of actions to be monitored very closely, all in one area, and reported on, and the evidence shared very easily. This has been noted by both CQC and NHSE, our colleagues, as a really innovative and very good piece of work. So I just wanted to highlight that on behalf of the team and the very clever assurance and compliance midwife that I have that actually built that. So I'll pause there and take any questions.
Thank you, Justine. I've said it in various different places. There's the two most important things we do is to bring life safely into the world and allow life to leave the world with dignity. So our midwifery services are disproportionately important to our citizens. And with respect to the CQC feedback, it's great for them to comment on how quickly you've responded to their points of clarification or questions. So thank you. Questions and perspectives to Justine. Colin?
Thanks, Jim. My question's on that point. Was there anything that CQC fed back to us that came as a surprise?
No, Colin, we knew all of the things that they raised, we were aware of. There was a couple of very small practice issues that they've raised that we weren't aware of. Obviously, we would expect our staff to follow the guidance that we have and use the equipment that's in place. But all of the other things we were aware of, and we had plans in place to deliver those. And the CQC inspector, he did actually say to me, I think if we'd have come in another 6 months' time, most of these plans that you've already started to enact would have been in place. So that was really good that we were able to demonstrate that as well. And he picked that up from the visit.
Yeah, great. Thank you, Justine. And Tony, then we'll move on.
Yeah, sure. Thanks, Chair. I'd just like to commend the move for as much of this information into the public domain as is safely possible. I think it's definitely a step in the right direction, and it's the right thing that we should be doing. So thank you for that, and well done.
Thank you, Tony.
Thank you.
Okay, Justine, please thank all of the team. Justine, I know I'm only recently joined. I would love to have a tour of the maternity unit with you, if we can arrange that over the next couple of weeks. I'm the NED safety champion for maternity at Warwick, so it would be great to see the Worcester way of doing things. So I look forward to that.
Of course, thank you.
Sue, your hand's gone up. I was just about to move on, but Sue, you're on mute, Sue.
I was just going to say, when you do that, can I come too? Because I'm new at doing maternity safety.
Okay, great. We'll do it together.
That would be lovely if you don't mind.
Okay. Anyone else who wants to join, of course, is able to join us. It could get a bit busy, but all comers are welcome. We'll move on then to the bed. Sorry, Sarah.
I was just going to say a big thank you, Russell, to the whole maternity team. Last week was extremely challenging, and a special thank you for Justine for the very late evenings that we put in to get the evidence back.
Great, thank you. And I know, because I went on until 9 o'clock at night on Friday, I know Justine, so thank you. Well said, Sarah. So we'll move on then to the bed cleaning report. Sounds like something you'd present a teenage boy with, but Sarah, over to you, the bed cleaning report, please. You're on mute.
So my mind's gone elsewhere now with that comment. This is kind of a legacy issue that I've kind of picked up from starting into post. So bed cleaning and whether we have designated bed cleaning facilities has been on the Trust C. difficile action plan since the 23rd of September 21. There have been various papers and specifications.
You're on mute again, Sarah.
Sorry, there's obviously something wrong with my computer. Is that better?
Yes, we can hear you now.
Okay, so there have been previous specifications pulled together over the kind of 2-year period around how much a designated bed facility would be within the trust, which ranged between 1.5 million and 3 million. And it's been difficult to understand where those proposals actually went. And there's no allowances or anything put forward within the trust capital plan around bed cleaning facilities, if that was the decision that the board was to make. So I was tasked by Dame Julie as chair of QGC to look into this and bring a proposal back to the board. So on page 3, I have given the bed cleaning national guidance. And what you can see there is that dedicated bed cleaning facilities are not a requirement of the Health and Social Care Act. What there are national standards of cleanliness which state how beds, what part of the bed and how the bed should be cleaned. And we have a current policy for bed cleaning, which for me, the issue is that we're not adhering to that policy, but that policy is compliant with national standards. So we do have audits in place from both the ward cleaning responsibilities, which is predominantly nurse and healthcare support worker cleaning responsibilities, and then the responsibilities of ISS, which is around undertaking our red cleans. So I'm not going to go into that in detail, it's in the paper. However, from our compliance audits, and something that I've really looked closely at since coming into post, is that the failures are actually predominantly in our ward cleaning. It's in our clinical teams, and the failures around the beds not being cleaned properly, which is kind of the cot sides, the top of the beds and the base of the bed. So because we've gone round and round in circles with this issue for the last 2 years, we actually looked at 7 other trusts across the region. We looked across the region and 7 trusts did come back to us. The other 3 trusts within the foundation group came back. And as you can see, out of the 7, there are only 2 hospitals that do have dedicated bed cleaning facilities. One is the George Eliot and one is the Royal Wolverhampton. But as you can see from the table, at this point in time of the year, both of those hospitals are over trajectory for their C. difficile target. And the only hospital which is in line with its trajectory and below trajectory is actually Swift. And they do not have a bed cleaning facility. So I think we do need to consider, though, that, you know, as a trust for C. difficile, we are the 2nd worst in region. So that is something that the board does need to keep in mind when you make the decision to accept or reject my recommendation. The other point from looking at Swift is that what Swift has done is a lot of work around antimicrobial prescribing and the ward rounds that take place. And it really is rewarding to have conversations with the clinical teams who have kind of put this in place. We are quite challenged just because we've not been successful in recruiting an antimicrobial prescribing pharmacy lead. However, we have got interviews in the next 2 weeks, and we are very hopeful with the candidates who come forward that we will appoint. And then what we will do is we will look to share learning from our foundation group partners. The other point that is impacting on our C. difficile is on the Worcester site, which we currently use bed cleaning machine, not bed cleaning, sorry, bedpan cleaning machines. Whereas on the Alex site, we use macerators for our bedpans. So we are about to trial using bedpan macerators on the Worcester site, and then we will need to make a decision what we do moving forward if the drains can handle using that machinery here. So my recommendation, given what's in the paper, is that we continue as we are, we do have an annual bed clean process in place. And our compliance audits from ISS point of view, compliance is high, and a real targeted focus on education and holding to account the standard role of matrons about making sure that our ward teams are undertaking their cleaning responsibilities. And if we don't see any improvement in 6 months' time, then actually we look at maybe a dedicated bed cleaning team as opposed to a bed cleaning facility, because I'm absolutely very aware just how busy our clinical teams are, and if there's something we can do differently. However, we would probably need to look at how do we do that within existing ward budgets. So I'll stop there.
Questions and perspectives, Julie?
I'm grateful to Sarah for doing this, because as she said, it's gone on a long time before she came, where we were trying to get to grips with C. diff. And at one point we were told we needed a dedicated bed cleaning facility, and we'd had one and it had gone. We've been past it went backwards and forwards for years, and finally we've got a plan, we've got a policy. We're not where we want to be, but at least we've got a plan to go forward on it, and we'll look at it again in 6 months. But this has gone on for years, so I'm very grateful to Sarah for this. And I will add as well that electronic prescribing should help with antimicrobial prescribing as well. Thank you.
Absolutely.
Thank you, Sarah.
Thank you, Julie. And I'll have Karen to come in and then go to Glenn. Karen?
Thank you. Yeah, also echoed Julie's thanks. Just one query or comment, I guess, observation, Sarah, which I'm sure is on your radar, that in my mind there's a slight nervousness about a dedicated cleaning team.
Absolutely.
Because fine, okay,
and that's why Karen, and I've had lots of conversations with, at my senior nurse meetings, and there is a push for that, but we should be cleaning our equipment as we go. It should be in our DNA. But somewhere along the way we've lost some of that. So, but we have already seen improvements over the last few months.
Yeah.
Thank you.
Thank you, Sarah. Thank you, Karen. And finally, Glenn.
Yeah, thank you to Julie for allowing us to finally put this issue to bed, so to speak. I don't know why we would be pursuing a capital spend on something that is about compliance. I actually do think antimicrobial prescribing is a really important element of that. And Karen's just said what I was going to say. I wouldn't be keen on a separate team, because I think it is important that this is everyone's responsibility and part of the nursing role, but also part of the role of our contractors for the ward cleaning routine. So I think that's maybe something you might want to talk about under the next item, how we ensure full compliance by our PFI partners on their cleaning responsibilities.
Yeah. I think it just need to keep things moving. So if you're not happy to accept Sarah's recommendation, could you please raise a digital hand? Okay, Julie approved. So we're back with you, Sarah, I think, for that IPC update. Over to you.
Okay, so this was an update on where we are with managing the PFI contract. So I'm conscious that Scott isn't here, but we have been having conversations with the PFI contract holder, and we have escalated our significant concerns, particularly around one of the providers. And we are now just finalising meetings for mid-November for a senior director to meet with Glenn, myself, Helen and Scott, with a view to then inviting that director in to a board development session following that, hopefully in December. Where we are around CPE is that we have, well, the contract holder has held the two contractors to account to put forward a proposal of how we can manage the CPE that we now know is in our kitchens. So I'm expecting that fully costed proposal to be with us by the end of next week. And then a future update will come to the board.
Okay, super. I'm really looking forward to our PFI partners joining us in a board development session. Questions and perspectives on that update from Sarah?
I would say, sorry, Russell, I would just say the responsiveness is improved significantly.
Yeah, and I was just about to build on that. Thank you, sir. I think it is important for our PFI partners to recognise it is a partnership, and any embarrassment that we would have over an infection prevention issue, which was down to their failing to do what they are paid to do, would clearly be corporately very embarrassing for them. So there is a real joint interest in them sort of engaging actively with us, and I'm sure the session that you described that Glenn will have will help them focus even more on their responsibilities. But we look forward to the board development session as well. Thank you, Sarah, for the update, and keep us briefed. Please do not hesitate to use any of us on the board to help you in those discussions should you need, if they start to stall. We'll then, on the subject of accountability, move on to the accountability framework, which is for approval. And Helen, we're back with you. Helen.
Thank you, Chair. I'm just going to do a little introduction, then I'm going to hand over to Chris Douglas, who's going to take us through the paper and the key points. So we've talked about the accountability framework now for a number of months, and I know the framework itself has been through a lot of the committees, but this really sets out our framework and our approach to performance and delivery across the trust, both in ops delivery, quality workforce and finance. And this, it also sets out how divisions will sort of have the opportunity to develop that more freedom and autonomy around the work that they do as they become more highly performing and deliver against the standards that we would expect their performance across all of those four elements. So I'm going to hand over to Chris, because this actually is Chris's baby, and Chris can take you through the key points and take any questions. Over to you, Chris.
Thank you, Chris. Over to you.
Thanks, Helen. Thanks, Chair. So I'll take the paper as read. There's a few elements I would just like to draw to the board's attention, if I may. So robust oversight and assurance through the accountability framework will sort of sets out the systems and processes for accountability for our effective performance management and operational delivery. It's focusing on whether we can be assured that we are doing what we say we will do, and then taking the necessary actions to recover where necessary, and being clear on the consequences. But success is dependent on the quality of leadership at all levels across the organisation in the implementation of the framework. It does provide, in my view, that a consistent approach from departmental to board level across the four domains that Helen's mentioned around operational delivery, quality, workforce and finance. But it's important so that we're having conversations not in isolation around individual topics, but that broader piece, which is why there's four domains in one place is really important. It's underpinned by the requirements of the operational planning guidance and the NHS oversight framework. Those are at its core, but it's heavily dependent on our business planning cycle to set out and be really clear on what we're expecting of our divisional teams to deliver in year and be held accountable for. It does establish the finance performance executive to replace our existing divisional performance review meeting structure. And that's almost the key mechanism for which the oversight and assurance conversations between our executive team and our divisional teams will take place, and where they will be held to account for delivery. In the short term, clearly, that's where we're going to be holding to account for delivery of the financial and performance recovery that's so important in terms of our organisation. It also establishes then those two key groups around hospital flow and elective and cancer delivery. And that creates that greater peer-to-peer accountability and for delivery and those two operational key priorities for the organisation, but is also inclusive of our corporate teams and the roles they play, because our success is everybody's business. The idea of the framework is it's delivery focused, so it does use data. We do need to understand what has happened in the performance to date, but also then using that information to understand the drivers for our performance and the actions that we're taking, and therefore the accountability around accountability of delivery of actions. And the other element, just to draw to attention then, obviously, is that piece that Helen alluded to around the tiering system. So this introduces a tiering system for our divisions. We'll call them 1 to 4, with 1 being our high performing divisions, which would earn more autonomy, and 4 were those are most challenged. So for what that would mean then is the level of oversight and assurance and the level of support that we'd be offering and putting in place for those divisions. So where they are most challenged, it's then how the organisation wraps itself around those divisions to support them to deliver, because we all want success for all of our partners. The other bit just that isn't included in the paper is that the other proposal then was that as part of Audit and Assurance Committee, where this paper was presented recently, is that we would take a review back to that committee in 6 to 9 months post implementation in terms of how well it's been adopted and implemented in the organisation. Happy to take any questions.
Really clear, Chris. Thank you very much for this. I do think it's an important element of making sure we improve our operational grip going forwards. Questions and perspectives. Karen?
Thank you, Chair. Yeah, I would agree. Really clear, really helpful. Absolutely support the principles of it, and particularly that of earned autonomy. One bit for me that I wasn't quite clear on was how we will ensure the link from our strategy and the 10-point plan all the way through to individual objectives, which clearly will drive the performance that is set out in the accountability framework, and how we get that golden thread and it links through to the improvement schemes that are in place. I didn't quite get a sense of that from the paper. Apologies if I've missed it, but that was what I was querying.
Okay, great, good question. I'm not sure who's Karen. Sorry, Helen.
Yeah, thank you. Karen, this touches somewhat on some of the things that we talked about in workshop, really around making sure that we've got a clear set of objectives that come out of the 10-point plan, and that are that go through the executive directors, through the divisions, and then through in each one of the divisions, and through into the directors, and then down through individual appraisals and PDRs, and what my intention would be from that point of view is pull the divisional objectives all together and bring that through the committee, so that the board are assured that actually the divisional objectives reflect that, and then we bring updates on a quarterly basis, particularly either through F&P and TME, against where we are against those objectives. And that's sort of the framework that I'm quite used to doing, so that we can just start to see the movement on all of those things and actually the delivery against that.
I think the other thing, before I invite Joe and Karen, is all non-execs will be invited to be observers at the Finance and Performance Executive. So we're able to be give ourselves some assurance in those meetings as to the level of golden thread, I think is a phrase you used, with the 10-point plan. Joe, is there anything you'd like to add to Helen's answer?
So I suppose I'm starting from the other end, from the strategy downwards, and I think it's a really valuable point you make, Karen, and I think something we recognise through the leadership summits we've been holding as part of introducing the forward improvement system, about how we sort of move from the strategic down to the delivery and the operational, as Helen has described. Chris brought this to the Transformation Guiding Board, which provides a good opportunity to think about how we can link this through some other work we've been talking about, which is actually, we've described it as catchable, but it's actually how do we translate some of those priorities into those actions. That's a piece of work that we've been wanting to support the divisions with. And I know Chris has also been talking to my team, both from an annual planning, business planning cycle perspective, and also for Jazz from the improvement perspective, to try and make sure we can build some of that in further. I think the NHS impact piece I referenced earlier has sort of come in since that conversation, so we might just want to go back and make sure we've covered that off.
Thank you, Joe. I think the absolute priority over the next 18 months is delivery of core operational performance standards on flow and finances, as the 10-point plan sort of indicates. We need to demonstrate to our citizens and to ourselves that we are substantially improving our performance delivery, and this, I think, is absolutely key to making sure that happens. Any other questions or perspectives to Helen or Chris? So, Chris, when would we expect the first Finance and Performance Executive meeting to occur?
So, Chair, the first Finance and Performance Executive is planned for December. That should be in diaries already, hopefully, for colleagues.
Okay, hopefully the beginning of December, Chris, rather than towards the end of it, but thank you very much. So if you're not happy to approve this, could you please raise a digital hand? Okay, duly approved. Thank you very much. And thank you for your hard work, Chris and Helen, in your sort of guardian role. We'll move on then to the safest staffing report. Over to you again, Sarah.
Thank you, Russell. So I will be brief. I'm taking the paper as read. So just really to provide assurance that paediatric and neonatal staffing and neonates was met BAPM standards and was safe, as was the staffing in our adult areas throughout August. We have outlined the number of insignificant harm incidents which occurred throughout July due to staffing, and that was 39. And we are having a targeted focus on healthcare support worker recruitment, and we are making good inroads on that in the last few months. And just really to update the board that we are working together as chief nurses across the foundation group to align our safer staffing nursing workforce papers, and we hope to have that in place by December. So we'll be able to learn and share the best practice and provide wider assurance across the group in that regard. So I'll stop there.
Thank you, Sarah. Any questions to Sarah? I'll come on to you in a second, Justine, on the safe staffing report on nursing. Now, the only thing I'd add is an encouragement to members of the public. In November, at the start of November, we have our first foundation group 4 board meeting, where we bring together all 4 boards of the foundation group, and members of the public are invited to that. It provides a really interesting opportunity to look at the different performance benchmarks across the foundation group. And I know from other members of the public in different geographies that they find it a very interesting meeting, but it sort of builds on Sarah's point about identifying and sharing best practice across different parts of the foundation group is what we're about. Justine, in terms of the maternity safe staffing, anything you'd like to add?
Yeah, so we have got obviously similar issues in terms of support staff that I covered in the previous report, but I just wanted to highlight the pipeline of midwives that we were expecting to come in across September and October and through to November has been successful, and they have arrived on time and as expected, which is great. And we've got some start dates already for those who are joining us in November. So as we sit today, we've got a 6% vacancy rate for midwives. And as we go into November, once the next group arrive, we'll be down to a 3% vacancy, which is a really, really good position to be in. I think you can see within the report what we are safe. We're meeting our acuity 84% of the time prior to any mitigations being taken. And obviously those mitigations are effective. We are still using agency. That will stop at the end of October, now that that pipeline has been successful, and we've also been able to maintain safe staffing levels using PA shifts, which have proved very, very effective. Unfortunately, we weren't able to maintain the supernumerary status of the shift leader in month, and we have an action plan around that, and that is quite linked to the theatre business case, and obviously positive recruitment. So I'll stop there and take any questions.
Thank you very much, Justine. Any questions on midwifery staffing? Really great work in terms of recruitment, Justine and Tina, so thank you very much for all of the efforts that you've been putting into that. Okay, we'll move on then, if colleagues are happy, to the Guarding a Safe Working report. Alec, nice to see you. Are you leading off on this?
Yes, hi, good afternoon everyone. Just give me a minute. Just coming off another meeting, just give me a minute, please.
Nothing like an Excel spreadsheet. Oh, no.
Can you see my screen? There has been some issues with sharing early.
No, we can see the screen, and you're looking even more handsome in that photograph, Alex. So,
thank you. I always try to put an older photograph on that, I'm afraid. Thanks a lot for that.
No, when you get to my age, you try and put much younger ones on, but it looks good. Back with you.
Hi, good afternoon, everyone. I recognize quite a few of the names for the other people. I'm Dr. Alec Raj Kumar. I'm an anesthetic consultant and also a guardian for sight working for the Trust. So the reason I'm here is I was requested to give a summary of exception reporting and briefly about my role. Particularly, the report covers the early part of this year or early quarter of this year. So most of you are aware of it. For any new people in the meeting today, exception reporting is a way how the junior doctors can flag up if there is any variation from their work schedule. It could be due to their work pattern or if any missed training opportunities. That could include any of those. So every trust is supposed to provide a platform where junior doctors should raise any concerns about their contract or if they're working particularly very much beyond their contracted hours. In our trust, we use the allocate system. And commonly, the report which we found is if they're working beyond their contracted hours, particularly staying late or unable to take breaks. But there are other instances where they arise, there has been insufficient clinical support and if they have missed any formal training opportunities. So I'm just going to share some data on, just bear with me, hopefully. So this is the report, as such the formal report which went to the People and Culture Committee and today is being presented to the board. And it comes under the workforce. And here the assurance says it's green. I've been guided by the HR and our board members on that. If you could see, if we can't, I'll just expand the screen a bit more. That's the summary. Sorry, the slides are a bit busy. I will take it through in a nutshell. The things to focus on here is that's between the different divisions in the trust. And the total number of exception reports for the early quarter of this year is 40 reports, which has been given. And these are the patterns which it comes across. Commonly, it is they are just working beyond their working hours. That's what most of those were. Some of this is it's beyond their working pattern, but many times that the trainees have made a mistake when they put a report on which table they're selected when they put the report on. So most commonly, you can combine these two because the HR and I keep a close eye on whether there's a change in the pattern. So this is not true, but mostly it's beyond their working hours. And there are some occasions where they have missed their training opportunities. For example, their formal teaching, if the wards are very busy or, many times if we are in different situation, the trust is busy in A&E, we have to call back trainees occasionally. And there is one immediate safety concern on this occasion. It is within the surgery department. I will touch on that in my presentation. So this is the data in a very much a nutshell. Otherwise, it becomes very complicated to present in 10 minutes on. So as expected, the summary of it is mostly it came from foundation doctors. That pattern has been consistent. That's quite understandable because when they come off the medical school, that transition is huge when they join the acute trusts. And the one immediate safety concern is because of we just escalated to the CD and the divisional director. After further conversation with them, we understood on this occasion it's due to the acute short notice of a sickness and which left with one trainee in the wards. After further investigation, the tutor sat down with the trainee and there is an escalation pathway exists in the department now, how to ask for further help. And in future, if this happens, to escalate it immediately to the consultant on call. So that is resolved now, but there's no harm cause to any patients or anything, but that's the reason for the immediate safety concern. There is another ongoing issue called self-development time. That's like our SPA for the consultants, for the trainees, particularly for the foundation doctors. The contract says we need to give them 2 hours per trainee per week. The problem with the number of trainees, it's quite difficult to monitor and give a separate contract for every single different trainee. As for foundation doctors are concerned, what we have done is we have combined those 2 hours after the teaching program on Tuesdays so that it's more consistent, so they don't miss it as well. Occasionally, if they are when they are on call, sometimes, or if the wards are busy, if it doesn't happen, we encourage the department and the trainees to negotiate on an individual basis. So there's a lot of improvement has been made, but still occasionally it exists on there. This is the summary of the table, what you saw earlier, but I can take questions at the end. What I do as a guardian is to increase awareness how the trainees are supported as per exception reports, or I give a talk during their induction on both the sites and educate them how to access our program. And any new supervisors or existing supervisors, we do an in-house training for them. And we also do which I didn't put it on the screen, there is also an open office and lunchtime workshop for the supervisors if they have got any doubts to how to close it on time. If there is any immediate safety concerns or assistance with specific reports, I'm available for them, and it's escalated to the CDs and the divisional directors. And there is regular guardian and HR meetings on a 6-weekly to 7-weekly basis so that we close the reports as for all the information is available and they are paid in time if it merits a payment. So moving forward as a trust, how we can improve this is Christian has been very supportive on this. There is a business case for a junior doctor liaison officer. The reason for this role is it will help us to close the reports on time because still there is a lot of reports unclosed by the supervisors. And also the software which we use in the hospital is Allocate as in consultant appraisal. I'm in talks with the HR to communicate with the, with that company to see whether they can send some automated reminders from the system if it's not done in time, just like our appraisal system. That will improve our data and it looks a bit more robust. The data will look a bit more robust. That would help us at trust. Sorry, I was just given only 5 minutes to talk about this, but that's the nutshell of the early quarter of this. But I'm happy to talk or answer any questions if anyone have got in the team.
Alec, thank you very much. And thank you, if you like, for volunteering for this one. We really appreciate your commitment. Questions and perspectives, Karen?
Thank you, Chair. Just a quick question. I wonder if you have any data or information on comparisons. So I think you said that we had 40 exception reports in that quarter. And I'm interested in what the sense is that high, low in comparison to other organisations, similar organisations?
Thank you for the question, Karen. This was asked in the People and Culture Committee as well. I just took up this role earlier this year, actually, from January. I don't have any past data on that. There is one national conference every year. I was hoping to go there. It was supposed to happen in September. I was hoping to go there and get a lot of comparisons with the other hospitals. Unfortunately, it was cancelled due to the strikes. I don't have a new date yet. And in the meantime, doing some literature search and speaking to different hospitals, that number seems to be very variable depending on the size of the hospitals and depending on the number of junior doctors. And also, it depends on the awareness, how much we give the junior doctors as well. With the junior doctor strike, I found the numbers have gone up. Particularly, it's very topical. The hours they are working, they want to get paid for any extra minutes or hours they work. I find there is a trend of increasing exception reports. That necessarily doesn't mean that we are doing badly. It just shows actually we are engaging with them better and addressing the issue. That's my view on that. I don't have a specific comparison tool to compare with other hospitals at the minute, but I'll look into it in future.
Alec, can I suggest, obviously Worcester has now joined the foundation group with Swift and George Eliot and Wye Valley. I'm sure Christine would be able to join you up with colleagues elsewhere in the foundation group, so that you can start to share best practice across all the different parts of the geographies the foundation group serves. And Simon?
My question, Alec, was do you feel that our doctors in training, our junior doctors, are confident enough to report when they feel things aren't going right? Do we have the right culture, the right openness, the right encouragement for them to speak up when they feel things aren't as they should be?
Yes. So thank you. Yes, we provide them different platforms for it. One is, so this could be done either in their workspace or at home as an exception report. So there's no time limit. They don't have to do it on the same day. So that gives them opportunity to reflect on that and raise it whenever they want. The second thing is there are some junior doctors forums that's done very informally and formally as well. So there is another platform they could raise it on time, any concerns they have got. And also recently, even just last week, we appointed the trainee reps so that they could work very closely among themselves. Actually, if there is any concerns, they can raise it to the rep and they can come back and talk to me about it. Or we also given them a list of support structures, right from educational supervisors, director of medical education and postgrad tutors, the list of them where they can approach it. And on top of this, I just went slightly beyond our trust. And for example, there are some national platforms like Doctors in Distress now. That is charity along with the Royal College of Psychiatry has introduced the system. So I just got the details and passed it on to a junior doctor. So if they got any personal issues or any issues which confidentially has to be raised, they can approach that system as well. So there are different platforms they could timely manner, they can bring it on.
Great. Thank you, Alec. Thank you, Simon. And finally, Christine, and we'll move on.
Yeah, just to say we are already sharing some learning across the foundation group. So, for example, Wye Valley has got better compliance with releasing doctors for their 2 hours of non-clinical time, and they do that by consolidating it into one block so that they get a half day or a whole day off, and we're looking at doing that as well.
That's great. Thank you, Christine. Alec, thank you very much. One of the things I'd always encourage junior doctors to consider doing is to ask to attend a board workshop, or indeed listening to a public board meeting to see how the whole hospital hangs together and the different challenges we have, to give them a broader perspective of the way the whole healthcare system works. So Alec, maybe when you're talking to junior doctor colleagues, you might want to encourage them, and you're always very welcome just to come along and be in attendance and see what the board does. But for today, thank you very much, Alec, and keep up the great work, and thank you for all your efforts. We'll move on then to the responsible officer's report on medical revalidation. Christine, over to you.
Yeah, I'll be very brief, Chair, as all the information that you need is in the report. So this is a report that is required to be presented to board for assurance that the medical and revalidation process is occurring in the trust as per the statutory requirement. For the last reporting year, we have had only 9 doctors who have had a delay in their appraisal, which has not been approved. So we approve delays due to things like maternity leave and long-term sickness. That's about 2% of the doctors in the trust. Those doctors are under active management by the appraisal and revalidation team to help them to get back on track. Over this revalidation year, we made 63 recommendations for revalidation. of which 56 were revalidated, 5 were deferred, and that was mainly due to delays in completing their 360-degree appraisal process, which needs to be completed once every appraisal cycle of 5 years. And in most cases, that was due to the doctors being redeployed or having less patient-facing duties due to COVID. We have also appended to the report the framework for quality assurance, which requires signature of either the chair or the chief executive for submission to NHS England to state that we are complying with our statutory responsibilities.
Super, thank you very much, Christine. Any questions to Christine? Christine, this is slightly off the wall and you may not know the answer, in which case, if you could just drop me a note. But given that the revalidation work we do, what percentage of our consultants do private practice?
I don't know. I will take that outside of the meeting and email you, Russell.
Okay, that's great. Thank you, Christine. Okay, colleagues, any other questions, Christine? Okay, so we'll move on then to the audit and assurance report. Colin, anything you'd like to fill out?
Take it all as read, Chair, with the exception of item 2, which relates to the UEC, where we saw some information regarding the processes which took us from the initial appraisal right through to approval of the project. And what we have decided to do is that we want to look at it in a more forensic fashion, get through some of the initial sort of governance processes to understand what happened underneath the surface. And Helen and Neil have undertaken to do that for us. So we will be bringing back a more detailed report to audit and assurance, and then I will be able to answer the question that you asked me, Chair, at the last meeting, which is how we got to where we are now.
That's great, Colin. And I think it is very important. The new UEC is a fantastic facility. We need to make sure it has the impact that we want it to have for members of the public. But at the end of the day, it has cost an awful lot more taxpayer money than was initially anticipated. So it is very important we show proper process of understanding of how that happened. Thank you, Colin. Any questions to Colin on the audit and assurance report? Okay, thank you very much, Colin. So we'll then move on to the board assurance framework. Erica, welcome. Thank you. What would you like to pull out of this?
I'll take the report as read, please, Chair. Going forward, it's interesting as a new starter on the board. I'm looking forward to sort of getting in to the BAF and also understanding the high risks as well, and developing the linkages with the BAF, between the BAF risks and high risks, and working with Sarah to develop the risk management process further.
Okay, thank you, Erica. Any questions to Erica on the BAF? So any other business, colleagues? Please raise a digital hand. And I think, Joe, you're the only sort of members of the public we've got with us, but as you are with us, any question you'd like to ask us?
Not really. I was just going to say that I thought the 10-point plan was very interesting. And I think one point I would make about, particularly around the home first, there's a cultural piece about home is best, but also there's a very much more specific one about preparing patients so that it doesn't come as a surprise to them that they're going home and their families, because we have had a few, sort of instances where we've been informed where, people turn up to see their mother and found they've been discharged. So there's that's quite an important comms piece. But I suppose the other thing I'd just like to reflect on is how it's coming across the shared learning and support that's coming from being part of a wider group. And it's quite nice to see those offers of support and shared learning coming through. Thanks.
No, thank you, Joe. And thank you for your work at Healthwatch. It's incredibly important for us to hear the rounded view of citizens on the experience of the health system and our part within it. We know we need to do a much better job for our citizens. All of our staff, their families will use Worcester Acute or the Alex or Kidderminster at some point. So there's a real sort of shared benefit in us getting better in terms of A&E in particular and discharges. We're hanging on to patients, as you've heard us say, for too long. Our length of stay is much higher than it should be, and the consequences in terms of hospital-acquired functional decline and hospital-acquired confusion, it is very real. Okay, team, thank you. That's the end of the public board. We'll have our private board in 15 minutes, so I'll try and save the executive some time. So I'll see you again in 15 minutes. Grab a cup of tea and a ginger nut, and I will see you then. Simon, sorry, your hand's gone up.
Sorry, Russell. It may be that this has not been taken on this occasion, but I thought we were going to take corporate trustees for the charity, but I may be mistaken.
No, you're not wrong, but I'm assuming we'll do that in 15 minutes.
Fine by me.
Okay, see you then. Thank you.